Next disease. Here patient is inhaling a microorganism and getting symptoms such as a fever, cough, shortness of breath. What is this common disease? Pneumonia. So write down what is pneumonia. Pneumonia is an acute respiratory illness. Pneumonia is an acute respiratory illness. Acute respiratory illness means patient can have combination of this: fever, shortness of breath, cough, chest pain. Patient can have any combination of these symptoms. Acute respiratory illness: fever, shortness of breath, cough. Along with that, you have taken a chest X-ray or CT scan. There is radiological pulmonary shadowing. It is acute respiratory illness with radiological pulmonary shadowing. This is considered as pneumonia. Write down the classification of pneumonia. There are many classifications. First we will discuss classification based on site of occurrence. Classification based on the clinical manifestation. Pneumonia, it is an acute respiratory illness. Patient will have fever, shortness of breath, cough, combination of these symptoms, chest pain with radiological pulmonary shadowing. So write down the classification. We have community acquired pneumonia and nosocomial pneumonia. Nosocomial pneumonia is a broad terminology. It includes both hospital acquired pneumonia, ventilator associated pneumonia. Let us start with community acquired pneumonia. As the name mentions, it occurs in communities. It occurs in communities. Hospital acquired pneumonia, it occurs in hospitalized patients. It occurs in hospitalized patients after 48 hours of hospital stay. Patient should have stayed in hospital for more than 48 hours. Ventilator associated pneumonias, it occurs after 48 to 72 hours of which type of mechanical ventilation? IMV. What is IMV, students? Invasive mechanical ventilation. Invasive mechanical ventilation means you will put a tube into the trachea and give ventilation. Ventilator associated pneumonia occurs after 48 to 72 hours of invasive mechanical ventilation. Let us see the organisms. For community acquired pneumonia, most common cause of community acquired pneumonia will be Streptococcus pneumoniae. Then if they modify the question like this: most common cause of community acquired pneumonia resulting in hospitalization. Most common cause of community acquired pneumonia resulting in ICU admission. What will be the answer? Here what they are asking is, there is a patient with community acquired pneumonia, and because of that pneumonia he got admitted into hospital. Because of that pneumonia he got admitted into ICU. What will be the organism? When you find community acquired pneumonia in the question, whether it is hospitalization or ICU admission, the single best answer is always streptococcal pneumonia. Coming to hospital acquired pneumonia, most common cause of hospital acquired pneumonia. If they ask you group of organisms, your answer should be gram negative bacilli. If they ask you single organism, your answer should be Staph aureus. As a group, it is gram negative bacilli. As a single organism, Staph aureus. Then ventilator associated pneumonia, it is classified into two forms. We have early VAP and other is late VAP. Early VAP means it happens within 5 days of invasive mechanical ventilation. Late VAP, it happens more than 5 days of invasive mechanical ventilation. For early VAP, the organisms, we have Streptococcus pneumoniae. Early VAP, most common is Streptococcus pneumoniae. And next important is Haemophilus influenza. For late VAP, most common will be Pseudomonas. Along with that, its best friend Staph aureus and their newfound love Acinetobacter Ventilator associated pneumonia, late VAP is very important. Most common is Pseudomonas, Staph aureus, Acinetobacter. Now if you see here students, in the question, if they mention community acquired pneumonia, your answer should be streptococcal pneumonia. Community acquired pneumonia, streptococcal pneumonia. For hospital acquired pneumonia, gram negative bacilli. For early VAP, again it is streptococcus pneumonia. Late VAP, Pseudomonas. And also VAP overall, again your answer should be Pseudomonas. VAP overall also is Pseudomonas. Then most research on nosocomial pneumonia was actually focused on ventilator associated pneumonia. Most of the data regarding nosocomial pneumonia is on ventilator associated pneumonia. So if they just mention most common cause of early nosocomial pneumonia is nothing but early VAP. Most common cause of late nosocomial pneumonia, it will be late VAP. So once they have asked what are the causes of early nosocomial pneumonia, your answer should be streptococcus. Late nosocomial pneumonia, your answer should be Pseudomonas, because nosocomial pneumonia, the data is more on ventilator associated pneumonia. So whatever is known regarding ventilator associated pneumonia, the organisms, the same will be applied for nosocomial pneumonia if they just ask common cause of nosocomial pneumonia. See, right now they will not ask such non-specific questions, they will be specific: early VAP, late VAP, HAP, CAP. So this is the first type of classification based on where the pneumonia is happening. Is it in the community? Is it in the hospital? Or is it in the hospital after connection to an invasive mechanical ventilation? The next classification is based on clinical presentation. Clinical presentation, on the basis of clinical presentation, pneumonia can be divided into typical pneumonia, atypical pneumonia. Typical means something usually happening. Atypical means something unusual. First let us discuss about typical pneumonia. How does a routine pneumonia present? Consider this is the alveolus. The bacteria will come into the alveoli and it will start proliferating. To fight against the bacteria, your body will send some immune response. Interaction between bacteria and immune response will result in production of secretions. So this patient, because it is an infection, he will have fever. Because secretions are formed, patient will have cough with productive sputum. So this patient will have productive cough. Like any other infection, there will be predominant neutrophilic leukocytosis. Now if you collect these secretions and see under microscope, sputum gram staining, because the alveoli is containing organisms, there is sputum. This sputum gram staining reveals organisms. You can see organisms under microscope. If you take a chest X-ray, all these alveolar secretions can be seen as alveolar exudates consolidatory pattern. This is how a routine pneumonia presents. Patient will come to me with a fever productive cough. In his blood, neutrophils will be elevated. His sputum will show organisms. Chest X-ray will show alveolar exudates. Now coming to atypical pneumonia. Let us see the unusual pneumonia. Let this be one alveoli. Let this be another alveoli. Here also the organisms first reach the alveoli, but they are not interested to stay in the alveoli. They go into the interstitium and start proliferating. They go into the interstitium and start proliferating. Against this also your body is going to give an immune response, because this is also an infection. Patient will have fever. Because of interstitial irritation, their interstitial inflammation, there will be some irritation. That irritation will result in cough. Now tell me students, how is the cough of atypical pneumonia different from typical pneumonia? In atypical pneumonia, there are no secretions in the alveoli, because the inflammation is not happening in the alveoli, it is happening in the interstitium. So patient will have dry cough, or some organisms may be present, only few. In that cases, there can be scanty sputum. There can be very scanty sputum. Then here I notice only mild leukocytosis. You can notice only mild leukocytosis. If you collect these secretions and see under microscope, generally gram staining reveals no organisms, because organisms are not residing in the alveoli, they are in the interstitium. And if you take a chest X-ray, you don't see alveolar filling, you don't see alveolar exudates, you find only a hazy pattern called as interstitial pattern. What is this interstitial pattern? I will show you on X-rays. What you see is called as an interstitial pattern. So there will be no particular alveolar exudates, because alveoli are not filled with the secretions. What you see is only interstitial pattern. Now if they ask you, what is the most common cause of typical pneumonia? Your answer should be streptococcal pneumonia. Most common cause is streptococcal pneumonia. Along with that, other causes are Staph aureus, Klebsiella, Pseudomonas. But most common is generally streptococcus. Most common is generally streptococcus. Then in the question, if they ask you most common cause of atypical pneumonia, most common cause of atypical pneumonia, always your answer should be mycoplasma. Mycoplasma. Apart from mycoplasma, Legionella, chlamydia, and various viral pneumonias are generally atypical pneumonias. So most common cause of atypical pneumonia, mycoplasma, Legionella, chlamydia and other viral pneumonias. Now if they modify the question like this, most common cause of atypical pneumonia, most common cause of atypical pneumonia resulting in ICU admission, Now what should be the answer? Most commonly atypical pneumonia is caused by mycoplasma. Generally mycoplasma pneumonias or mild pneumonias, it does not require ICU admission. But if there is an atypical pneumonia responsible for ICU admission, the most common organism in that will be Legionella. The most common in that will be Legionella. But for the past 1.5 years, atypical pneumonia resulting in ICU admission, it has been COVID. but if you see for decades together, it was Legionella. So most probably that may not change. So till then, most common cause of atypical pneumonia is in ICUs. So most common cause of atypical pneumonia resulting in ICU admission, it is Legionella. So in the question, if they mention typical pneumonia, most common cause Streptococcus pneumonia. If they mention atypical pneumonia, most common cause Mycoplasma, and most common atypical pneumonia resulting in ICU admission, it will be Legionella. It will be Legionella. First we will see what are the important typical pneumonias. We will see what are the important typical pneumonias. Then we will go into important atypical pneumonias. Make a table, students. First, important typical pneumonias. I am going to discuss how streptococcal pneumonia, how staph pneumonia and Klebsiella pneumonia behave. Based on those risk factors, what are the important risk factors, what are the specific clinical features, and what will be the chest X-ray finding, and finally treatment. Coming to risk factors, for streptococcus pneumonia, smoking is an important risk factor, and streptococcus pneumonia is the most common pneumonia happening in diabetics, alcoholics. Streptococcal pneumonia is the most common pneumonia happening in diabetics and alcoholics. Then the clinical features. I will only discuss the classical clinical features, not general. What are general clinical features of any pneumonia, students? Fever, cough, shortness of breath, chest pain. Whereas specific clinical feature, classical clinical feature of streptococcus is red rusty sputum. One can notice red rusty sputum. Then the important chest X-ray finding in streptococcus is called as lobar consolidation. Now what is this lobar consolidation? If you consider this is the lung, lobar consolidation is localized involvement of segment or lobe of lung. It is localized involvement of segment or lobe of lung. It is localized involvement of segment or lobe of lung, and this is considered as most common pattern in community acquired pneumonia. Most common pattern in community acquired pneumonia. Now treatment for streptococcus is generally beta-lactam antibiotics. Then coming to staph pneumonia. Staph pneumonia, it is also called as IV drug users pneumonia. It is called as IV drug users pneumonia, and it can occur as fatal pneumonia. It occurs as fatal pneumonia post-viral illness. If they mention in the question, this patient recently recovered from a viral illness. Now he has developed a bacterial pneumonia that resulted in death of the patient. What might be the bacterial pneumonia? Your answer should be staph pneumonia. Clinical features. These patients can have mucopurulent sputum. And the classical chest X-ray finding, it is called as bronchopneumonia. What is this bronchopneumonia? If you consider this is the lung, there will be bilateral patchy consolidation. This bilateral patchy consolidation, it is called as it is called as bronchopneumonia. It is called as bronchopneumonia. Whenever we discuss about staph, it can cause some specific radiological features called as pneumatoceles. There can be pneumatoceles. There can be formation of lung abscess. There can be formation of lung abscess. There can also be formation of cavities. Now what are these pneumatoceles, lung abscess, cavity? I'll show you everything on a chest x-ray. Coming to the treatment part, by the time a patient reaches me with staph pneumonia, it will be already MRSA. MRSA means methicillin resistant staph aureus. For them, the treatment I advise is vancomycin. But nowadays, there is rapid resistance to vancomycin. If the patient is VRSA, I am going to give linezolid. Because the resistance of vancomycin is very prevalent in our community. Whenever I see MRSA, I am directly starting linezolid. Whenever I see methicillin resistant staph aureus, nowadays we are directly going for linezolid. Coming to Klebsiella pneumonia, the risk factors: malnutrition, alcoholism. Even though for Klebsiella, alcoholism is a risk factor. By number, common pneumonia in alcoholics is still streptococcal pneumonia. Coming to the classical sputum. In Klebsiella, the sputum will be red and gelatinous. This is called as red currant jelly sputum. The classical sputum in Klebsiella is the red currant jelly sputum. Coming to the classical chest x-ray finding. Consider this is the lung, especially the right lung. In the right lung, there will be a horizontal fissure. Klebsiella causes dense right upper lobe consolidation, very heavy consolidation, very heavy consolidation. Because of this huge consolidation, the horizontal fissure which was straight previously will slightly bulge down like this. There will be right upper lobe consolidation, with the classical bulging fissure sign, Normally your horizontal fissure will be like this. Because of dense right upper lobe consolidation, your horizontal fissure will bulge down. This phenomena is called as bulging fissure sign. Apart from that, in Klebsiella, one can notice cavity. It can cause pneumatoceles. It can result in lung abscess. Cavity, pneumatocele, lung abscess can happen. Coming to the treatment. Treatment includes combination of beta-lactam with aminoglycoside. Treatment is combination of beta-lactam along with that aminoglycoside antibiotics. So very important, students, in the question if they mention red rusty sputum, lobar consolidation, your suspicion should be streptococcus. Bronchopneumonia, IV drug users, your suspicion should be staph. Red currant jelly sputum, bulging fissure sign, your suspicion should be Klebsiella. From this table, the examiner can make multiple clinical scenario. So you should be knowing which organism fits there and you should answer accordingly. You should be knowing which organism fits and you should be able to answer properly. So okay, students. So this completes important typical pneumonias: streptococcus, staph, Klebsiella. Now another typical pneumonia will be your Pseudomonas. So write down Pseudomonas. Where are we routinely seeing Pseudomonas pneumonia nowadays, students? It frequently occurs as ventilator associated pneumonia. Whereas in the community, if they ask you most common cause of pneumonia in cystic fibrosis, bronchiectasis, all these terms mean nearly the same. Structural lung diseases, cystic fibrosis, bronchiectasis, structural lung diseases. What should be your answer? Pseudomonas. Along with that, its best friend staph can also exist, but best answer is Pseudomonas. Coming to the clinical features, in the Pseudomonas infection, patient can have fever, mucopurulent sputum. Fever, there can be mucopurulent sputum. And if you take a chest X-ray, one can notice bilateral infiltrates. Coming to the treatment, for Pseudomonas, you should give 2 antibiotics. Most important will be anti-Pseudomonal beta-lactam. What is anti-Pseudomonal beta-lactam? It is a beta-lactam with activity against Pseudomonas. What are the important names? We have piperacillin tazobactam, cefoperazone sulbactam, meropenem. So all these higher beta-lactams will be required for treatment of Pseudomonas. Along with that, you should add a fluoroquinolone or aminoglycoside. Most important will be anti-Pseudomonal beta-lactam. Next important pneumonia is Acinetobacter pneumonia. Now where is Acinetobacter happening? This also occurs as ventilator associated pneumonia. Now what will be the treatment for Acinetobacter pneumonia? Initially we give carbapenems. If the organism becomes resistant, the next option is colistin. Recently asked question, which of the following drug is helpful in management of Acinetobacter pneumonia? The option was colistin. Now if you notice here, both these Pseudomonas and Acinetobacter frequently occurs as ventilator associated pneumonia. Now let us see how actually ventilator associated pneumonia is happening and what are the methods that we can use to decrease incidence of ventilator associated pneumonia. We will see what are the mechanisms and what will be the methods to reduce ventilator associated pneumonia. Now first of all, how ventilator associated pneumonia is happening? So whenever you are intubating the patient from the oral cavity, you can push some secretions into the respiratory tract. When you are putting tube from the oral cavity, some secretions can go into the respiratory tract. As long as the tube is in place, along the walls of the tube, organisms from the oral cavity can descend into the lung. And third important thing, that ventilator itself is a huge source of infection. From the ventilator, organisms can go into the tube. From the tube, they can go into the lungs. So 3 important mechanisms. While inserting the tube, as long as the tube is in the oral cavity, along the walls of the tube, organisms from the oral cavity can descend into the lower respiratory tract. And from the ventilator, directly organisms will go into the tube, from the tube into the lung. Now what are the methods to reduce ventilator associated pneumonia? First method is elevate the head of the bed 30 to 45 degrees. If the patient is completely supine like this, it will be easy for the organisms to descend down. So I am going to elevate head of the bed 30 to 45 degrees, and daily in the morning I am going to clean his oral cavity with chlorhexidine. So once you do chlorhexidine cleaning, the oral cavity organisms will decrease and less chances of going into the lower respiratory tract along the tube. And third important thing, at some point of the day I am going to reduce his sedation. So once you reduce his sedation, his cough reflex will come back. So this patient can cough the secretions at least up to the trachea, and I can suck out the secretions. And finally, wherever feasible, I should use NIV instead of IMV, because NIV has less chances of ventilator associated pneumonia. So write down methods to decrease ventilator associated pneumonia. So first important is elevate head of bed, elevate head of bed 30 to 45 degrees. Second method, oral decontamination. So I am cleaning his mouth with chlorhexidine to make sure his oral cavity is not harboring any organisms. Third, sedation vacation. I am not sending him anywhere. Vacation means giving a break. I am giving a break to his sedation so that his cough reflex will develop and at least he can cough the secretions up to the trachea where I can suck it out through suction. Then use of NIV. Use of NIV wherever feasible, instead of IMV. Use of NIV wherever feasible instead of IMV. Recently asked question, does frequent change in endotracheal tube, does frequent change of endotracheal tube, is it beneficial for reducing ventilator associated pneumonia? That was the question. Your answer is frequent change of endotracheal tube. Frequent change of endotracheal tube, it is not beneficial. It is not beneficial in reducing ventilator associated pneumonia. This was the question asked. Frequent change of endotracheal tube, is it beneficial in reducing ventilator associated pneumonia? Your answer is no. What is the reason behind that? Each and every time you put a new endotracheal tube, you yourself are causing organisms from the oral cavity to go into the lung. Each time you put a new endotracheal tube, you are pushing some oral secretions into the lower respiratory tract. So what will be the methods to decrease ventilator associated pneumonia? Elevate the head of the bed 30 to 45 degrees. Oral decontamination with chlorhexidine. Sedation vacation. Use of NIV wherever feasible instead of IMV. Frequent change of endotracheal tube not beneficial in reducing VAP. So in this slide we have discussed about ventilator associated pneumonia, the mechanisms, how to avoid, and the common organisms, what to give for Pseudomonas, what to give for Acinetobacter. Now let us see common atypical pneumonias. We will discuss in the same way we have discussed typical pneumonias in the form of a table. On one side Legionella, on other side Mycoplasma. One side Legionella, on other side Mycoplasma. For Legionella, most common method of transmission, Legionella, most common method of transmission will be aspiration followed by aerolization. Aspiration followed by aerolization. The reason is Legionella is spread through contaminated water. It is spread through contaminated water. Point to remember here, students, these patients are going to drink that contaminated water and later the organism can aspirate into the lungs. That is the most common mechanism. The second mechanism is they can inhale aerosols from the contaminated water. That can also result in Legionella infection. But most common is through aspiration. Aspiration followed by aerolization. Whenever I discuss about Legionella, you should discuss about its special features. What are the special features of Legionella pneumoniae? Along with pneumonia, the patient will have associated diarrhea. Associated diarrhea. Because of diarrhea fluid loss, there can be hyponatremia. Because of CNS involvement, there can be confusion, there can be headache, there can be altered LFTs. Why altered LFTs? As a part of systemic involvement, liver can be involved. That can result in altered LFTs. This is an atypical pneumonia. If you collect the secretions and see under microscope, you cannot identify organism. Gram staining reveals no organism. Gram staining reveals no organisms. Then, for some unknown reason, there is poor response to beta lactams. Commonly given antibiotic is beta lactams. This infection, there will be no response to beta lactams, and it generally occurs in, this infection occurs in old age and immunocompromised. Old age and immunocompromised. If you see in the question, occurrence of illness within 10 days discharge from hospital. Occurrence of illness within 10 days discharge from hospital. One possibility is Legionella. Now, what is this entity? Occurrence of illness 10 days within 10 days discharge from, occurrence of illness within 10 days discharge from hospital. Now, this Legionella has a prolonged incubation period, 7 to 10 days. Today, patient might be admitted to hospital because of some other disease. So, he might have taken the contaminated water, got infected with Legionella. Now, this will not manifest immediately. Now, patient might be discharged and in the home the disease might be manifested. So, here what happens is patient might be infected in the hospital. Because of its prolonged incubation period 7 to 10 days, it will not manifest immediately. It will manifest at home. If you see a clinical scenario, occurrence of illness within 10 days discharge from hospital, within 10 days discharge from hospital, one suspicion should be Legionella. Now, coming to diagnosis of Legionella. So, diagnosis. So, this is an atypical pneumonia. Generally, gram staining is difficult, and also culture, the results will be delayed. So, diagnosis, we are having an urinary antigen test for Legionella. We are having an urinary antigen test, and other methods are serology. We look for antibodies against Legionella antigen, and if available, PCR. PCR is nothing but polymerase chain reaction. Here we are going to identify the specific genetic material. Urinary antigen test is commonly employed. Serology, PCR, polymerase chain reaction for Legionella. Now, coming to mycoplasma. As we know, this is most common atypical pneumonia. Mycoplasma is most common atypical pneumonia. This is also called as eaten agent pneumonia. Eaten agent pneumonia, after the name of the scientist. This is called as walking pneumonia. Now what is this walking pneumonia? Mycoplasma will cause pneumonia. Generally it is a mild form of pneumonia. Patient is having pneumonia and he is doing his routine activities such as walking. It means whenever there is a patient with pneumonia, it causes significant illness. So he cannot move. He will be taking bed rest. But mycoplasma will cause a mild pneumonia and patient can do his routine activities such as walking. So that's why it is called as walking pneumonia. So don't ask me which is called as dancing pneumonia, running pneumonia. There are no such terms. Because mycoplasma causes mild pneumonia, patient can still do routine activities and he can walk. That's why it is called as walking pneumonia. When we are discussing about mycoplasma, you should know about its extrapulmonary features. Even though it is rare to have extrapulmonary features, but they can be asked in the exam. What are those extrapulmonary features? In the skin, there can be rash, erythema nodosum. In the skin, rash, erythema nodosum. Within the CNS, as a part of systemic involvement, CNS involvement, encephalitis. And patients who recovered from mycoplasma later on can develop Guillain-Barré syndrome. Who recovered from mycoplasma later on can develop Guillain-Barré syndrome. Then within the blood, one can notice increased cold agglutinins. One can notice increased cold agglutinins. And patients with mycoplasma pneumonia have tendency to develop hemolytic anemia. Very important. In the question, if you notice, students, in the question, if you notice pneumonia with diarrhea, your answer should be Legionella. Pneumonia with hemolytic anemia, your answer should be mycoplasma. Then in the heart, CVS, it can cause myocarditis. It can cause pericarditis. And within the joints, it can cause arthritis. And one important feature for this mycoplasma organism is there will be no cell wall. Now this feature of having no cell wall, how will it influence me in diagnosis and treatment? Because there is no cell wall, you cannot do gram staining. Because there is no cell wall, commonly given antibiotics called as beta-lactams will not work. Why is it so? Because beta-lactams require cell wall binding proteins to exert its function. So for diagnosis, in mycoplasma also, you cannot do gram staining and culture will be delayed, not reliable. For diagnosis, here we rely on serology. Look for antibodies, and if available we go for PCR. See, the diagnosis for Legionella and mycoplasma is nearly the same. Whereas Legionella has a specific urinary antigen test, mycoplasma we go for serology to look for antibodies against mycoplasma in the patient's blood. If available, we try to identify the genetic material through polymerase chain reaction. Now coming to the treatment, let it be Legionella or mycoplasma. In both, commonly given antibiotics called as beta-lactams will not work. Then what will be the treatment? Treatment is common for both. Let it be Legionella or mycoplasma. You can give any of this drug. You can give either fluoroquinolones or macrolides or tetracycline. Any one of the following can be given for treatment of any of these pneumonias. But if they specifically ask for Legionella, preferred is fluoroquinolones. That too respiratory fluoroquinolones such as levofloxacin, moxifloxacin. For mycoplasma, preferred will be macrolide. Preferred macrolide is azithromycin. Very simple. Let it be Legionella or mycoplasma. Any one can be used as treatment. But if they specifically ask for Legionella, your answer should be fluoroquinolones. For mycoplasma, your answer should be macrolides. For mycoplasma, your answer should be macrolides. So this is an important table which will tell you the difference between Legionella, mycoplasma, and here the treatment is generally common. Coming to VIP, very important pneumonia, pneumocystis pneumonia. Whenever I say pneumocystis, what is the disease that should come into your mind? HIV. It is only because of pneumocystis pneumonia HIV was eventually discovered. Such is the importance. Write down pneumocystis pneumonia. This is a pneumonia in immunocompromised. This is an pneumonia in immunocompromised. What do you mean by pneumonia in immunocompromised? It means infection can occur in any but disease only in immunocompromised. It means anybody can inhale pneumocystis and can get infected with pneumocystis, but for the patient to develop active disease, he should be having an underlying immunocompromise. And what is the most common immunocompromise responsible? HIV. Now let us see few associations with HIV. What is most common opportunistic infection in HIV worldwide? Pulmonary manifestation in HIV, pneumonia in HIV, pleural effusion in HIV, fungal pneumonia in HIV. There is lot of controversy regarding this. Let me solve this with some authenticity. As of now, most common opportunistic infection in HIV worldwide is tuberculosis. Most common pulmonary manifestation. Whenever a HIV patient presents to me with some respiratory symptoms, what I should suspect? Some infection in the lung. What is that infection in lung called as? Pneumonia. It can be pneumonia. Now what is common cause of that pneumonia? Common cause of that pneumonia is again tuberculosis. Most common cause of pleural effusion in HIV, tuberculosis. Most common cause of fungal pneumonia in HIV worldwide. Don't forget, right now pneumocystis is a fungus. Yesterday it was a protozoan. Tomorrow what it will be? Only God knows. Till then, if they ask in the question for fungal pneumonia, then only your answer should be pneumocystis. Write down the risk factors responsible for development of pneumocystis pneumonia. As I mentioned previously, most important risk factor is CD4 count less than 200 per microliter in HIV patient. Then second risk factor, patients who underwent organ transplant. Organ transplant will also be given some immunosuppressive therapy to prevent the graft rejection reaction. So that's why they also will be immunocompromised. They also can get pneumocystis. Then patients on long-term immunosuppressive therapy. They might be on some steroids, they might be on some chemotherapy. Long-term immunosuppressive treatment. And patients with some other primary immunodeficiency syndromes. Patients with some other primary immunodeficiency syndrome. Out of all these risk factors, most important is CD4 count less than 200 microliter in HIV patient. Now coming to the clinical features, this can manifest as an atypical pneumonia. So atypical pneumonia in the sense, patient will have fever, there can be dry cough, and what do you notice? Shortness of breath. Now coming to the chest X-ray features. If you consider, this is the lung of the patient. Initially the chest X-ray can be normal. Patient will be having fever. Patient will be having pneumocystis disease, but chest X-ray will be normal. Later one can notice perihilar infiltrates. There can be perihilar infiltrates. These perihilar infiltrates can progress to bilateral interstitial infiltrates. Perihilar infiltrates can progress to more diffuse form, bilateral interstitial infiltrates. Apart from this, pneumatoceles and pneumothorax can be seen. Pneumatoceles and pneumothorax can be seen. Previously asked question, a normal chest X-ray in a HIV patient can rule out pneumocystis pneumonia. Is it true statement or false statement? It is a false statement, because initially chest X-ray can be normal. A normal chest X-ray cannot rule out pneumocystis pneumonia in HIV patient. Now coming to the diagnosis. This is a atypical pneumonia. Even if you collect this sputum, you cannot find organisms. Then what will be the ideal sample? The ideal sample will be bronchoalveolar lavage. So what I am going to do in bronchoalveolar lavage is I am going to put a bronchoscope and I am going to inject some saline. This saline will go into the alveoli, hit the alveolar walls and bring the organisms. So for diagnosis of pneumocystis pneumonia, the sample should be ample, and that sample is ball. So write down, for diagnosis, the most important sample is ball when compared to routine sputum. Now with this bronchoalveolar lavage, what exactly I should do? I am going to visualize this cyst. I am going to see the organism, visualize this cyst with help of special staining. We have gomari, methamine silver stain. We have gomari, methamine silver stain, right Giemsa stain. All these are various stains. Gomari, methamine silver stain, right Giemsa stain, or the advanced immunofluorescent staining. Advanced immunofluorescent staining. So with this I am going to visualize this cyst. Now after visualization, the diagnosis, next will be the treatment. What will be the drug of choice for treatment of pneumocystis? Very, very important. If this is pneumocystis, this is what cotrimoxazole does to it. it will make it run for its life. Drug of choice for treatment will be cotrimoxazole. Now few patients with HIV are at risk of developing pneumocystis. What will be the drug of choice for prophylaxis? For prophylaxis also the answer should be cotrimoxazole. For prophylaxis also the answer should be cotrimoxazole. Now if the patient is not tolerating cotrimoxazole, what are the alternate drugs available? We have trimethoprim plus dapsone, trimethoprim plus dapsone. Then next important thing is clindamycin, clindamycin plus primaquine, atavoquone, atavoquone, pentamidine, pentamidine. These are all alternative drugs, but for all practical purposes, if you see pneumocystis, drug of choice for treatment for prophylaxis, single best answer will be cotrimoxazole only. A recent question: what is role of steroids in pneumocystis pneumonia? Will you routinely give steroids or you should avoid steroids? The answer should be I should avoid steroids. But there is a situation where steroids are indicated in pneumocystis. That was asked previously. Where in severe pneumocystis pneumonia. So whenever there is severe pneumocystis pneumonia, large fungal population is residing in the lung. Now if you give cotrimoxazole to that patient, cotrimoxazole will degrade the fungus. When such a large amount of fungal filaments are released into circulation, it will cause a severe inflammatory response which is not good for the patient. In those conditions, to bring down the inflammation, a short course of steroids will be helpful. So here also in severe pneumocystis pneumonia, so the cutoff PaO2 is less than 70 mmHg. In severe pneumocystis pneumonia, when do you call it as severe? When PaO2 is less than 70 mmHg. Here also the primary drug of choice is cotrimoxazole only. So when you give cotrimoxazole, there will be degradation of large amounts of pneumocystis. So many pneumocystis are getting damaged. That releases fungal filaments. These fungal filaments can cause a severe inflammatory response. To bring down that inflammatory response, steroid therapy will be helpful. It is just like a teamwork. So Bahubali and Katappa. Here Bahubali, the one who kills, is cotrimoxazole. So cotrimoxazole will kill the fungus, and whatever inflammatory response is generated, it is taken care by steroid. Kindly remember, in severe pneumocystis pneumonia also drug of choice is cotrimoxazole only. So cotrimoxazole will kill the fungus. Whatever inflammatory response is going to happen, it will be taken care by steroid therapy. It is a teamwork. Cotrimoxazole kills the fungus, steroid will take care of that inflammatory response. So generally that problem happens only in severe pneumonia whenever there is large fungal population. So we restrict the use of steroids only in severe pneumocystis pneumonia. Now there is a patient with pneumonia. He has come to your hospital. How will you assess the severity and decide whether to admit him or whether to send him home or whether to admit directly in ICU? For assessment of severity of pneumonia, there is a scoring system called as CURB65, CURB 65. C stands for confusion. U stands for blood urea more than 7 millimole per liter. R stands for respiratory rate more than 30 per minute. B stands for either systolic blood pressure less than 90 mmHg or diastolic blood pressure less than 60 mmHg, and 65 stands for age more than 65. For each variable we are going to give 1 point. Now you can get a doubt, this is pneumonia. Why am I concerned about confusion, blood urea, blood pressure? The point to be noted here is, any infection in severe form can cause multi-organ dysfunction. In that multi-organ dysfunction, if brain is involved, confusion, if kidney is involved, renal dysfunction and increased blood urea, if there is septic shock, there will be decrease in blood pressure. So if many variables are present, it means patient is having a severe infection. Now if the score is in the range of 0-1, for these patients, home treatment with antibiotic is advised. If the score is 2, I am going to hospitalize and treat. If score is 3 to 5, I will consider this as severe pneumonia. And patient may require ICU admission. If score is less, I treat him at home. So management at home is called as outpatient treatment. Score 0 to 1, this is called as outpatient treatment or OP treatment. If score is less, we prefer outpatient treatment. If score is more, we admit the patient. Admitting the patient is called as IP treatment, inpatient treatment. So outpatient treatment and inpatient treatment. Now the next concept, if I admit him in hospital, what is the preferred antibiotic therapy? If I am sending him home, what will be the preferred antibiotic therapy? So write down empirical treatment of community acquired pneumonia. First thing what you should know is, where exactly you are treating the patient. Is it at home? It is called as outpatient treatment. Whenever you are treating at home, you prefer tablets, or is it inpatient treatment in the hospital? In the hospital we prefer injectables. Generally we prefer injectables more than oral forms. So very simple, where exactly? Is it outpatient treatment where we give generally tablets, or is it inpatient treatment where we generally give injections? Now if it is outpatient treatment, I should inquire, is the patient having any comorbidities? With comorbidities, no comorbidities. Comorbidities in the sense, patient might be having diabetes, hypertension, kidney disease, previous heart disease, lung disease, liver disease. No comorbidities means patient is not having any of this. If patient is not having any comorbidities, the treatment is simple. I give either beta-lactam or macrolide, any one, or tetracycline group. Either beta-lactam or macrolide. Either beta-lactam such as simple amoxicillin, macrolide such as azithromycin, tetracycline usually doxycycline. Now, if the patient is having comorbidities, the first choice will be combination of beta-lactam with macrolide or monotherapy with fluoroquinolone. Monotherapy with fluoroquinolone. Now, if the patient is admitted in the hospital, where exactly? Is it in the ICU or is it in the ward? That is non-ICU. If the patient is admitted in non-ICU, what will be the preferred treatment? So, preferred treatment will be beta-lactam plus macrolide or monotherapy with fluoroquinolone. Monotherapy with the fluoroquinolone. Now, if the patient is admitted in ICU, the first preferred will be beta-lactam with macrolide or the second preferred is beta-lactam with fluoroquinolone. Beta-lactam with fluoroquinolone. Beta-lactam with fluoroquinolone. Now, if the patient is in ICU, there are few special considerations. If Pseudomonas suspected, what will be your regimen if Pseudomonas is suspected? Now, this patient should be started on the regimen against Pseudomonas, anti-pseudomonal beta-lactam, along with that a fluoroquinolone, Now, this patient is with community acquired pneumonia. He is in ICU, and during your rounds you found out this fellow is a chronic IV drug user. Now, what you will suspect? You will suspect MRSA. If community acquired MRSA, because this patient has come from the community, if CA means community acquired MRSA suspected, what will be the choice of antibiotics? See, the first regimen will be combination of beta-lactam plus macrolide plus vancomycin. There is another regimen or the second regimen, it is combination of beta-lactam plus fluoroquinolone plus linezolid with or without clindamycin. Right now, this is considered as most effective regimen for staff in the ICU. So, this regimen, combination of beta-lactam, fluoroquinolone, linezolid with or without clindamycin. Now, you should get a doubt. You are suspecting it to be MRSA. You are suspecting it to be community acquired methicillin resistant staph aureus. Then why are you giving beta-lactam macrolide, beta-lactam fluoroquinolone? What is the reason behind this? See, this patient is in ICU. One suspicion is staph. It does not mean patient will not be having common organisms such as streptococcus or legionella. So, in this regimen, this beta-lactam macrolide, beta-lactam fluoroquinolone will take care of common typical atypical organisms, whereas the vancomycin linezolid will take care of the specific organism. So, the bottom line here is, whenever a patient is in ICU and you are treating for a severe community acquired pneumonia, you should give an antibiotic regimen which has broad activity against the common organism. Now if you see in this table, fluoroquinolone, even though it is a very good drug, it is not used as first line regimen. Fluoroquinolone is not used as first line regimen for community acquired pneumonia, especially in our country. What is the reason behind that? In India, there is high burden of tuberculosis. If you use all these fluoroquinolones for simple pneumonias, later if that population develops TB, it will be drug resistant. So write down important statement. In India, empirical use of fluoroquinolones, not indicated due to high burden of TB. So this is also a very, very important statement, students. In India, empirical use of fluoroquinolones not indicated due to high burden of tuberculosis. So whenever there is a patient with community acquired pneumonia, first see where you want to treat him by curb score. Is it outpatient or inpatient? If it is outpatient, you should know what to give if there are no comorbidities. Again, in inpatient treatment, if he is in ICU, what is the regimen? If he is not in the ICU, what is the regimen? And in ICU, special considerations. If Pseudomonas suspected, what you should give? If community acquired methicillin resistant staph aureus suspected, what you should give? So in this single table, I have completed the empirical regimens of community acquired pneumonia according to 20th edition of Harrison. Now I'll give you some clinical scenarios. You should tell me the organism. So this patient is having fever with red rusty sputum. And what do you see in the chest X-ray? Localized involvement of lobe. This is lobar consolidation. Now if you see this in combination, what should be the suspicion? Streptococcal pneumonia. Very important box. So just a brief revision. Already we have discussed. Fever, red rusty sputum and lobar consolidation. You should keep in your mind Streptococcus pneumonia. Brief revision. Another patient, fever, dry cough, and this is the chest X-ray. Now what do you see in the chest X-ray? You are not seeing any consolidation. You are only seeing some mild haziness. This mild haziness is interstitial pattern. When you see in this in combination, your suspicion should be atypical pneumonia. When you see this in combination, your suspicion should be atypical pneumonia, students. And what is the most common cause of that atypical pneumonia? So this is the interstitial pattern. You can see only mild haziness. So there is no actual consolidation, slight increase in density. This mild haziness is called as interstitial pattern. This is suggestive of atypical pneumonia. And in atypical pneumonia, most common, your answer should be mycoplasma. Nothing new. Whatever I have discussed up to now, I am putting into clinical cases. That is the new pattern, students. Now another patient, he is having fever and red currant jelly sputum, and chest X-ray is showing this picture. What is this picture? Normally your horizontal fissure should be straight like this. Even in the lateral view, it is straight like this, but it has bulged down. but it has bulged down. What is this phenomena called as bulging fissure sign? If you see this, what should be your answer? It should be Klebsiella pneumonia. Klebsiella pneumonia. What is the other name for Klebsiella? It is called as Friedlander bacilli. Either called as Klebsiella pneumonia or Friedlander pneumonia. Friedlander pneumonia. Key points are fever, red currant jelly sputum, bulging fissure sign. Fever, red currant jelly sputum, bulging fissure sign. Then, how to identify cavity of lung? What is cavity? Cavity is air-filled area. It is an air-filled area with well-defined wall. It is an air-filled area with well-defined wall. The usual dimensions will be more than 1 to 2 mm. How to identify cavity? First we will see in a CT scan. CT scan, to call it as cavity, always notice the air-filled area. This is the air-filled area. Around that you should identify the well-defined wall. Can you notice, students, around this air-filled area there is a whitish density. So this whitish density is nothing but its wall. Same thing you should also identify on the chest X-ray. This is the air-filled area. This is the air-filled area. Around that there is a well-defined wall. Around that there is a well-defined wall. So this is cavity, air-filled area around that well-defined wall. Now I will show you another air-filled area. Tell me, how is this different? This is also air-filled area, but there is no proper wall. See, you can see wall here only. Here there is no proper wall. This is called as pneumatocele. Pneumatocele is air-filled area. Air-filled area with ill-defined walls. Air-filled area with ill-defined walls. Where did we learn about pneumatocele? In which infection? It can happen in staph, Klebsiella, pneumocystis pneumonia. Staph, Klebsiella, pneumocystis pneumonia. Now keep this air-filled area in your mind. Now compare with air-filled area previously. Now what do you notice here, students? This air-filled area is having a good wall. So black area, around that whitish area is the wall. Black area around that whitish area is the wall. Whereas here it is an air-filled area, but you are unable to appreciate the wall. See the wall dimension, not seen properly here, very well seen here. This is the difference between cavity and pneumatocele. Sometimes these cavities can be filled with fluid. What is that entity? Lung abscess. Lung abscess refers to localized parenchymal necrosis. A part of lung is getting necrosed and destroyed. That is lung abscess. And in the chest X-ray, you have to notice this cavity with air fluid level. So first thing, there will be cavity. So this is the cavity. There is air and there is also fluid. To call it as a lung abscess, chest X-ray will show cavity with air fluid level. Coming to the classification, primary form. This primary form is most common form, happening in 80%. If I see 100 lung abscess cases, 80% of the cases will be primary form, and this primary form is generally due to aspiration. Because it is happening because of aspiration, most common organisms in primary form will be those residing in the oral cavity. What are they? Oral anaerobes. Primary form is due to aspiration. Because it is aspiration, the organisms will be oral anaerobes. And what will be the drug of choice or treatment of choice for oral anaerobes? See here. If these are oral anaerobes, this is what clindamycin does to it. So treatment of choice is generally clindamycin. Now secondary form, it is not due to aspiration. It is due to some pre-existing lung disease. It is due to some pre-existing lung disease that can complicate as lung abscess. Here the organisms can be either Pseudomonas, it can be staph, it can be Klebsiella, Pseudomonas, staph or Klebsiella, and treatment will be according to organism. You know what to give for Pseudomonas, what to give for staph, what to give for Klebsiella. So important point here is primary form is most common form. It is generally happening due to aspiration. In whom you will suspect aspiration? Alcoholics you suspect aspiration. When patient is having some neurological disease, in them also you suspect aspiration. Because it is due to aspiration, the organisms will be those residing in the oral cavity. What are the organisms residing in the oral cavity? Your answer should be oral anaerobes. And what will be the treatment against oral anaerobes? Your answer should be clindamycin. Now let us see some questions. Case number 12. A 20-year-old male. History of fever, cough, mucopurulent expectoration. Chest X-ray showing patchy infiltration. Multiple cavities. Sputum smear will show direct question. Mucopurulent, cavities, bilateral patchy infiltration, bronchopneumonia. Your answer should be staph. It is staph. Option C. A 32-year-old HIV patient with shortness of breath, moderate fever, on examination cyanosis is present with respiratory rate 32 per minute and some crepitations. Chest X-ray is given. It required bronchoalveolar lavage and we have done immunofluorescence staining. It was positive. Most likely diagnosis. So in the question, positive points: HIV with pneumonia because there is a fever, shortness of breath. And what is this X-ray? You see more of interstitial pattern. See this. See in the X-ray there is no consolidation, more of haziness. Interstitial pattern. Interstitial pattern. And it required bronchoalveolar lavage for diagnosis. That too immunofluorescent antibody. All these are suggestive of pneumocystis pneumonia. So the best answer is pneumocystis pneumonia. So why it is not streptococcus? Because streptococcus and staph will not have this interstitial pattern. Why can't it be mycobacterium? Mycobacterium can also occur with some interstitial pattern in very severe HIV, but mycobacterium we do not do any immunofluorescent antibody. We generally go for CB9. So this is not the typical presentation of tuberculosis, but this is a typical presentation of pneumocystis pneumonia. So best answer is pneumocystis pneumonia. HIV, pneumonia, interstitial pattern, requiring ball. What are you expecting? It is pneumocystis pneumonia. Curb 65 include all except SBP should be less than 90, not less than 100. The best answer is option 4. SBP should be less than 90, not less than 100. Then case number 14. There was a 26-year-old male, alcoholic, fever, cough, productive sputum, bad smell 10 days. He was admitted twice to the emergency department after being found unconscious due to alcohol intoxication. Chest X-ray is given. So he is alcoholic. Frequently he is getting unconscious. So there is possibility of aspiration and foul smelling sputum, plenty of sputum. All this indicates possibility of some necrotic infection. And on the chest X-ray, what do you notice, students? there is air-filled area in a cavity and fluid. There is lung abscess. Aspiration history plus lung abscess. What should be your diagnosis? Primary lung abscess. In primary lung abscess, what will be the organism? Oral anaerobes. And what will be the treatment of choice against oral anaerobes? Your answer should be IV clindamycin. So this is a primary lung abscess. So diagnosis is primary lung abscess and treatment of choice will be clindamycin. Now drug of choice for swine flu prophylaxis. Because of COVID, we completely forget about swine flu, but there are a few things that you should know. This swine flu is caused by H1N1 strain of influenza virus. H1N1 strain of influenza virus. If they ask you drug of choice for treatment, your answer is oseltamivir. And exposed individuals are also given prophylaxis. Drug of choice for prophylaxis again is oseltamivir. Very important, swine flu. It is caused by H1N1 strain of influenza virus. For treatment, it is oseltamivir. For prophylaxis, it is again oseltamivir. What are the other drugs that are helpful in management? Other drugs that we have are zanamivir, permivir, and the recently approved baloxavir. So these were recently approved, especially this baloxavir. But before these can be used, there was a COVID pneumonia which made us forget about swine flu. The drug of choice is oseltamivir. The best answer is oseltamivir. For prophylaxis also it is oseltamivir. Other drugs we have zanamivir, permivir and baloxavir. So this is regarding swine flu. So we have completed majority of pneumonia. So we have started with what is community acquired, what is hospital acquired, what is ventilator associated, what is typical, what is atypical, important typical pneumonias, important atypical pneumonias, pneumocystis, how do you assess the severity, empirical regimens, lung abscess. Then for each and every pneumonia we have taken a clinical scenario, we have seen X-rays, we have seen clinical features, we have correlated accordingly. Very important topic even in your clinical practice.